My name's Tiffany Gaines. I'm a registered nurse, have been for 22 years. I've been a nurse practitioner for the last 13, and the most recent 6, I've been here as a nurse practitioner at Calvert Internal Medicine Group. A big part of that is providing women's primary health promotion and disease prevention care. Breast cancer is the leading premature cause of death for women in the United States. However, it's not a disease of women only. It is estimated that 260,000 women and 2,600 men have invasive breast cancer in the United States. It's also estimated that approximately 41,000 women and 500 men will die in 2019 related to breast cancer. But that's just facts and numbers. What we're here for today is to give you the information that you need to help you, to prevent you from becoming a statistic. So let's start with some things that you actually can control that may alter your personal risk of developing breast cancer. The first one is being overweight in the postmenopausal years. Being overweight after menopause actually increases breast cancer risk. Women with a high body fat index have that higher risk of invasive breast cancer. Another thing that you can do to actually help prevent or lower your risk of breast cancer is to follow a Mediterranean diet, supplemented with extra virgin olive oil. That actually has been thought to be a primary prevention of breast cancer. Inactivity, unfortunately, is another thing that is thought to increase your risk of developing breast cancer. And conversely, the opposite, being a little bit more active, is thought to decrease your risk as well. Next, I'm going to give you some items over which, unfortunately, you have no control, but it's very important to be aware of them. Making sure that your primary care provider knows will help to enhance your screening and individualize your care. And that's really the main focus of our discussion this evening, and we will get back to that a little bit later. But first, as I'm going to say, we want to first talk about and make sure you understand those factors over which you have no control. We call those non-modifiable risk factors. The first one is family history. People who have a family history and a first-degree relative of breast cancer, ovarian cancer, prostate, or pancreatic cancer are indeed at increased risk of developing breast cancer. The second non-modifiable risk factors are inherited mutations. I'm sure a number of you have heard about these. We call them BRCA1 and BRCA2. Those happen to be responsible for 30% of all inheritable breast cancer. Not all breast cancer, just those that are truly inheritable. Another group of risk factors are related to reproduction. And these are items that, again, for the most part, you have no control over, but unfortunately they do increase your risk of breast cancer. The first one is never having given birth to a baby. The second one has to do with your reproductive lifespan. In other words, if you're somebody who started your periods really early in life or went through menopause very late, both of those increase that period of time that your hormones are very active, and this is thought to increase your risk of breast cancer. Never having conceived a baby or never breastfeeding. Those are two more non-modifiable risk factors. Conceiving your first baby after the age of 30 is also a risk factor. Recent use of oral contraceptives and menopausal hormone therapy, again, increase that risk. Another non-modifiable risk factor is having high-density breast tissue. The really nice thing is nowadays the mammograms actually give you that in a report. So you and your primary care provider are going to know that that is an additional risk factor for you. And discussing that with your primary provider will help ensure that the screening for you is done in a manner to best modify and monitor your breast health. Mammography is the primary diagnostic tool. The issue is that the guidelines differ about when to start and stop that screening. This is where we want you to be an active decision-making part of that discussion with your personal provider. We want to develop a personalized screening plan for you. We want to discuss those risk factors that were just mentioned, your preferences, and your beliefs. Do be aware, mammograms have benefits. Unfortunately, they also have possible harms, and these can be issues. We want you to understand that there can be false positive, false negative findings, as well as overdiagnosis. and how these may impact your health and your care, and how the information that you would get personally affects you mentally and physically. A false positive is a mammogram that prompts additional workup, more imaging, tissue samples, biopsies, and even in that person, no cancer is ever found. Again, that's a false positive. A false negative mammogram is one that shows up being a normal mammogram in a person who actually was found to have cancer. Overdiagnosis is a mammogram that shows there is something going on in there. However, even if you had never had treated it, it would have never caused you any health issues. Screening finds cancer. Screening saves lives. However, like I was saying, it can trigger unnecessary procedures. Things like testing recalls, more views of mammograms, ultrasounds, biopsies, mastectomies, systemic drug therapy, radiation, days off work, and out-of-pocket costs. Another way of monitoring or looking for screening for breast cancer is the self-breast exam. This has become rather controversial, and the newest guidelines are telling us to teach our patients to become breast aware. In other words, be aware of the normal appearance and feel of your own breast tissue. One of the things that you can do at home to help monitor your breast tissue is to stand in front of a mirror naked. What you're going to do is rise your hands up over your head carefully and slowly. And what you're going to do is watch that breast tissue rise across your chest wall. Breasts should be symmetrical, look basically the same left to right. Generally, most women have one breast that's larger than the other, and that's perfectly normal. What you're looking for when you raise your hands up over your head are any dimpling, retractions, places where the skin kind of puckers or pulls in, or if one nipple pulls in a lot more than the other. If you find any kind of those changes, you definitely want to make an appointment with your primary care provider. The other screening test is called a clinical breast exam, and that's one that's usually done at your annual or biannual exam with your primary care provider. But this really isn't something that's necessarily recommended for all women. The changes that you see, if you see any of those changes or find any changes in your general breast health, that's when you want to make an appointment with your primary care provider. Studies have shown that not doing that clinical breast exam significantly increases the number of breast cancers missed. Again, it can lead to additional testing, anxiety, or even the opposite, false reassurance or a delay in diagnosis. But do be aware, it is a low-cost, easy screening way to have your breasts examined. It may prompt testing that does need to be done. Change it over instead of a screening to a diagnostic mammogram, or even an ultrasound, or even prompt an ultrasound when in the past a mammogram has been normal. Women who are at average to moderate risk, the guidelines tell us that mammograms should be done approximately every other year, starting at age 50 and ending at the age of 75. But that's it. It's only a guideline. It's not an individualized plan for you and your situation. As you can see, there are a number of things to consider regarding breast cancer screening and awareness. The absolutely best thing you can do is make an appointment with your primary care provider. Discuss with them the best way to determine monitoring for you, the best frequency, the best modality. Again, that could be mammograms, teaching you more ways to monitor your breast health, clinical breast exams. We want to help you find the best way to monitor your breast health for you. We want to discuss with you your screening values, your preferences, and go back and remember, we want to discuss your personal risk factors. And that was that list we mentioned. Starting, stopping screening, and develop early detection plans and minimize the potential screening harms. So now I think we have just a little bit more time. So if any of you have any questions, we'll do our best to get to all of them, in case that we have any at this point in time. I have people that will help me with that.
So the first question is, if I've had breast implants, what does that mean for me?
That's a really good question. If you've had breast implants, the bottom line is they're still your breasts. your breast tissue is still there. It changes absolutely nothing. Generally speaking, we're still going to start doing your screening at 50. Generally speaking, we're going to end it at 75. However, you need to have that conversation still with your primary care provider. There's still all those risk factors to be determined, those modifiable as well as non-modifiable, those inheritable. It's really important to have those discussions, but generally, you're going to still follow the same guidelines. Part of the reason to go see your primary care provider once in a while based on having the implants, they're going to want to do maybe a couple of additional views or maybe an ultrasound. But generally, the screening's the same.
If I'm turning 75 soon, then what do I do?
Another really good question. The 75 ending kind of has to do with what some of the general thoughts are as far as life expectancy. But life expectancy is going up in the United States, as well as having healthy, much older individuals. Again, it's like a broken record. You need to have that conversation with your primary care provider. There actually are a number of women that we do monitoring well beyond the 75 years.
Sita says, at what age should I get my first mammogram?
Again, a really good question. That's where you have those conversations. It depends on your family history. If you're somebody who has a significant family history, especially of any of the inheritable breast cancers, you're going to start much, much earlier than 50. If you're somebody who has one of those first degree relatives, that's a brother, sister, mother, father, or even a child that has had a breast cancer, you're going to start that screening earlier. You're going to have those conversations with your health care provider. Learn how better to monitor your own breast health at home, and that's a really good place to start.
Butch asks, do a lot of males get diagnostic mammograms done?
Only if you had a change. It's not something that's done at all routine. I guess that's why it's called diagnostic. It does happen. If a male finds any kind of a change in his breast tissue, if one breast starts to get larger than the other, see your primary care provider. If you start to feel a lump, if you see changes, a dimpling, if you see changes in the nipples, if you see changes, this is for women as well, I apologize, changes in coloring of the skin over the breast tissue, bring those to the attention of your primary provider. And yes, men do get diagnostic mammograms, and those are usually accompanied by additional views as well as ultrasounds.
Pat says, did you say mammogram every other year? Is that what is recommended?
That is the newest recommended guidelines for women who are at average to moderate risk. If you have any risk factors that bring you into the higher end of risk, you're going to get them more often.
Patricia asks, how do you navigate all the information you get after surgery?
I'm not sure what kind of surgery you mean. I'm not sure if you're talking about because you've had implants or because you've had cancer. If it has to do because you've had cancer, that you're really going to want to have that conversation with your oncologist, because really different kinds of cancers get different kinds of treatments, and there are different lengths of period of time that you're going to do monitoring. So that one I really can't address. That one needs to go back to either your primary, or more importantly, if it had to do with surgery because of a proven cancer, then that's really going to want to go to your oncologist. If it was surgery for a suspected cancer, there aren't really solid guidelines, but usually, at least in my practice, I go ahead and do one the very following year, and then beyond that, go back to the every other if you're kind of back at a baseline for you.
Are cysts something that can turn into breast cancer?
True cysts, no. They're fluid, and that's why frequently women will get a cyst that gets larger. Those tend to change a little bit depending on where you are with your periods and your cycle. Also can have a big change based on caffeine intake. Some get large enough that they're causing pain and they get aspirated, and so they do still need treatment, but no, true cysts do not become cancer. All right, I think that's going to be it for this evening. We're going to wrap it up. Thank you so much for all of your questions, your attention, and we really enjoyed your time.